This conference will now be recorded.
Okay, so AnCan is grateful to the following sponsors for making this recording possible. Our sponsors are Bayer, Foundation Medicine, Janssen, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. Next month, John and Rick and I will be in San Francisco at the ASCO meeting and try to make that list a little bit larger in terms of people who support. We also have a number of the men who come to the group who choose to support, and we are appreciative of all the support we receive, no matter the source. AnCan respectfully notes that it does not accept sponsored promotion. Any drugs, protocols, or devices recommended in the discussions are based solely on anecdotal and peer experience or clinical evidence. AnCan cannot and does not provide medical advice. We encourage you to discuss anything you hear in our sessions and with your own medical team. Jose, you got in here before we got started. Is this your first time in this group?
No, I've been here before.
Okay.
But I'm visiting. I'm not.
Okay, great. No updates for us.
Thank you. No, thank you. No, not yet. Next week or the following week.
Okay, great. So
thank you.
Let's see here. Let's start with Sandy. You're new to the group today, so I'm going to want to go through some questions that allows us to get the information and get the discussion started for you. So, Sandy, how old are you?
72. I'll be 73 in May.
Okay, in Boulder Creek, California, Bay Area.
20 miles north of Santa Cruz, south of San Francisco, about up in the mountains.
And when were you diagnosed?
December of this last year, December 23rd, I believe. I got the news.
Okay, and what was your PSA, and how did they proceed from that?
Well, a PSA is never been above 4. It was 3.1. That wasn't the red flag that got me evaluated. It was frequent urination. I have low T, which the doctor said actually masks the PSA being high. So that was not a flag, but I've been evaluated from there.
Okay, and you had an MRI?
I've had a CAT scan, and I'm waiting for the MRI and also a PET CTA, PSMA.
Yeah, PET scan.
Both of which cannot occur until Feb 12th because they wanted to wait 8 weeks after the biopsy. I've had a biopsy.
So you had a biopsy before the MRI?
Correct. I believe because one of the tumors was so large, he wanted to get right in there and go right for the biopsy. That's a urologist, Dr. Gomini, in San Jose, California. Supposed to be one of the best. So, yeah, he went right for the biopsy.
Okay. And do you know, was it transrectal or transperineal?
It was transrectal.
Okay. And how many cores did they take?
12.
And how many were positive?
3.
And do you know what the Gleason score was?
Yeah, the Gleason score was 3 plus 4, 3 plus 4, and 3 plus 3 on the edge. So 7 overall.
Okay. And have you had a second opinion, send the biopsy off for a second opinion on the
No, I have an appointment on the 23rd of this month with a radiation oncologist. That will be one second opinion, and I have several other contacts for other if I need it. So yeah, I've got an appointment set up already for that.
Okay. And did they do a Decipher score?
Let's see. Mark, say that one again. A Cypress core?
A Decipher score. Did they
Oh,
do any biomarker test or genetic
not
testing?
yet, not yet. They said they were going to do the biomarker, but that hasn't been done yet.
Okay. Let me see here.
Let me volunteer that it was a T2C level is the conclusion so far from the main doctor urologist.
Okay, great. Anybody like to make some comments or ask questions to Sandy here? Okay, if not, I'll get started here. I am going to ask for people to help me today because my voice is half here and half going away. And therefore, I'd appreciate any help with that if possible. So first of all, in this day and age, usually doing a biopsy without an MRI is like playing pin the tail on the donkey. You don't know where to biopsy, and the biopsy takes such a small percentage that saying you're a 3-4 on the having 3-4 on the biopsy course is just a good guess and not particularly accurate. The MRI may show otherwise, but doing a biopsy without an MRI, I think most of us would hold suspect in this day and age. The other thing is that transrectal biopsies, while they have been the standard for the longest of time, they come with a risk of infection. And it can be significant. 1% to 2% of people can have severe life-threatening infections. And it's been estimated in the United States that about 1,200 people die each year from prostate biopsy infections. So the transperineal biopsies with sedation is becoming more and more common as a way to approach this. And then the Decipher score is taking the tissue from the biopsy and doing genetic testing to determine the likelihood that the lesion will spread. It's interesting that they were able to do the PET scan because normally the PET scan is held for those people who have more aggressive disease, like a Gleason 4+3. It would be good for 3+4. But again, it's iffy about whether the insurance company.
Mark, let me just correct one thing. I have not had the PET yet. That will happen on the 12th of Feb. What I did have is a CT, and I have the results here. And so far, it shows no spread, but that's just a general CT. No major organs, but
the CT and bone scan. Generally are not considered the standard today, and the PET scan is more of a standard. Again, that's something that was an older standard, but not particularly used anymore to direct treatment. So I'm not sure.
Like I may need another doctor here. My friend actually recommended this guy. He got sepsis after his biopsy and ended up in the hospital for 5 days. So the infection thing was a big concern. I took a lot of Cipro and a lot of antibiotics, but yeah, it's kind of surprising, I guess, that he went right for the biopsy, huh?
I would suggest that that's not a standard. I certainly wouldn't, in the years that I've learned on this, I wouldn't proceed or continue with someone who would do a biopsy without an MRI. The other thing that I might add is that it's helpful to get a second opinion on the biopsy. Not every hospital is going to do a good job, and you want to get people who are reading a lot of these slides, and that's primarily what they do. You don't want to see someone who in the morning is going to look at a breast biopsy and then a uterine biopsy and then maybe a prostate biopsy. You want to get someone who who does this on a regular basis. And the two places we recommend, one is John Hopkins in their GU pathology. And then the other is a Dr. Ming.zhou, ZHOU, at Mount Sinai in New York. And if you just Google either Ming.zhou and Mount Sinai prostate or Johns Hopkins prostate opinions, it's really easy. It costs somewhere around $350. They send your slides off. Nice thing about Dr. Zhou is that, and I think it's actually Joe, ZHOU, but I think he will get on the phone with you and explain what he thinks and what his recommendations are.
That is very, very helpful. My oncologist, I have a blood syndrome also. A lot of problems here, but she recommended a fellow at UCSF for another opinion up there, a GU oncologist. So my intention was to follow up with him after I meet with the radiation oncologist down here in the San Jose area. So sounds like I better look for several other opinions. I appreciate this information.
Well, Rick down in the corner here, at least down in the corner on my screen, had his treatment in San Francisco and can talk to, I don't know, the GU oncologist, Mac Roach in radiation there is one of the best. And you certainly can't go wrong there, but it is worth getting to see the best. Rick, do you have any recommendations?
Mac Roach has already been referred to me, and there's a like I say, another GU. I don't recall the name now, that my Stanford oncologist down here recommended. So I think I better seek them all out here before making any decisions. It sounds like, huh?
I think that's
what type of oncologist are you talking about? Are these radiation oncologists, or are these medical oncologists, or are these urologic oncologists?
Well, the next appointment is with a radiation oncologist, simply because my current urologist who did the biopsy recommended that surgery with all my other medical conditions, which I can go into if you'd like, probably take all night. But for example, I have wouldn't be a good idea. For example, I have a bovine aortic valve from open heart, very, very susceptible to infection from a surgery. And I have a low platelet count due to my blood syndrome, very low platelet count. So, surgery is pretty risky. So he said, well, why don't you see if radiation will work with this guy? So that's kind of where I'm at.
It sounds, Sandy, you and I have been in touch. It sounds like she's sending you, or they're sending you, to a radiation oncologist. When you came to us, you were talking about surgery. We don't see surgery. We're not medical. At least I'm not. I don't have a medical certification. We can't say that for everybody in the room. Some of them do, at least two that I see. But you didn't look appropriate for surgery. You do look a lot more appropriate for radiation. If you're going to get radiation, my recommendation would be the Mac Roach or one of the other radiation oncologists at UCSF, or Srinivas at Stanford.
Okay. How's that one spelled at Stanford?
I think it's Srnivas. He has a name similar to yours, Sandy.
Okay. Yeah, that's a nickname. Okay. Well, thank you very much. Like I say, I've got a number of paths here, but I think after meeting with the radiation oncologist and having the other two scans, then I'll be at a crossroads. I don't know if my intermediate is that T2C with 3 instances. Is that urgent? What do you all think about being in a hurry?
You don't need to see a medical oncologist. That's one person right now you do not, I don't think, unless you feel that you need to see a medical oncologist because of your related comorbidities. But that said, I would allow the radiation oncologist to refer you to the medical oncologist. You don't need to see a medical oncologist I don't think over treatment, but I could be wrong. What do the two docs in the room think about that?
Well, I think at this point that's right. And to answer your question, you're not about to die. You're not dying. You're not in a huge hurry. You don't have to panic and make a decision under a great deal of pressure. You have time to see all these other doctors and get these scans.
Okay, good. That's what I wanted to hear, and I sure appreciate this discussion. So, yeah, the GU oncologist I was told I do not need, so that that you all concur with that. My next step, as I say, is a radiation oncologist, and then I have again other contacts up at UCSF. Maybe I will, like Max Roach, for example, was one of the recommendations as well. So.
Yeah, by the way, it's Mac, M-A-C-K.
Yeah. I mean, I've seen his YouTube deal. Yeah. Okay.
Stuart, you had a comment.
Yeah, just on ming.zhou, just because I dealt with this over the last couple of days. Googling him does not get to a contact information.
Okay.
We were able to track it down, and in the chat, I put the email address that he provided, which is his suggested requested way of contacting him.
Okay.
And then he's got an email that he sends out with specific instructions on what needs to happen.
Okay, so would I then ask my doctor to provide the data to him directly, or he has obviously the biopsy info, the urologist who did the biopsy, or the lab, yeah.
If you send a note to that email address, they will send you instructions. Which, yes, you do go to you do request through your doc to send the stuff, but he has exact instructions on what he wants sent and where to send it, and and then they act on it within a couple of days of receipt.
Excellent. And how would I get that email again? You say it was in a chat somewhere?
I put it in the chat, which is the two.
Oh, up here. Let me open that. Oh, I see. Oh, very good. Oh, you guys have all got that here. Okay, very good. So thank you very much, Stuart. I'll go ahead and make a note of that right now. Okay, great.
Yeah.
Rick, I wanted to ask you, is it normal for most of the radiation oncologists to order follow-up and advise Sandy on, how much to rely on a blind biopsy? Or is that something that would go through a GU oncologist?
No, it would be with. I mean, if you spoke with Mac, it would be well within his wheelhouse. I think so, or Srinivas. I think those type of docs are going to tell you whether the blind biopsy was sufficient or not. I mean, it doesn't seem worth the while to see another urologist up there. If you did, then Peter Carroll would be really good, because he will direct you to the sort of he'll give you his opinion on the sort of treatment, which is going to be some form of radiation, and he would opine on that. Okay. But I know that at UCSF, Mac will tell you whether he thinks you need another biopsy or you don't need another biopsy for sure.
Sure. Okay, I think, well, this is real good information, guys, and I sure don't want another biopsy. So, but if that's
and just for everybody in the group, because it's easy to make mistakes, as one of our mods knows, there are two ming.zhous at Mount Sinai.
Okay.
You want the email address there. When you start Googling ming.zhou, you come up with ming.zhou and ming.zhou.
Oh, yeah. Okay.
So you have to be careful. that
Thank
you
you.
get the right one.
Thank you. I will get on that probably tomorrow morning. Thank you very much. Okay.
Okay. Any other questions that you have, Sandy, for the group?
Have any of you had treatments such as the radiation seeds or external radiation or surgery at this point? Any of you?
Well, I've had both seeds and external radiation.
Okay. And how long ago did that work out well for you?
So I was stage 3, and I also had to do 28 months of hormone therapy. And it has worked out very well.
Oh,
It was
congratulations.
in 2007 that I was diagnosed. 2000, I started my treatment, my hormone therapy in 2007. I had the radiation and seeds in early 2008. And right now I have a durable and continuing remission. But yes, it was a good option. I personally think that if you are a good candidate for it, the seeds are quick and easy and very effective.
Well, thank you very much. I'm very glad
The
to hear
problem is, although Mac may not agree, because he's sort of transitioned from seeds more to SBRT. So, that is a discussion. But I think seeds, and certainly if you can manage with seeds alone, that's a great alternative.
Okay. Well,
So I'm going to tell you that I think the seeds are not a good alternative for you because of the low platelets and bleeding disorder and such. So I would say that there are also on the group here people who've done SBRT, and I'd be a supporter of looking at SBRT.
Well, pardon my ignorance. What is SBRT now?
That's 5 days radiation, external beam radiation.
Oh, external beam. Okay, I got it. Yeah, my friend who referred me to your group originally, John Appler, had 6 weeks, he said, of external radiation, which cured him about 6 years ago. So I guess he had anything.
He had a lot more than that too.
Yeah.
Because I was one of the people that navigated John.
Oh, okay, good.
And John had similar treatment to me, except that he had, I think he had high dose brachy instead of getting the seeds, he had high dose brachy, and then he had IMRT. But that is probably not the situation that you're in.
Okay, thank you. Okay.
Jim Stuart, you wanted to make a comment. You have your hand up. Go ahead.
I just want to make a comment. I traveled to UCSF for Reno for treatment, and then thank you, Rick, for getting my referral to Dr. Carroll. And I just can't speak more highly of the entire organization there. I mean, I would recommend that facility, and everyone that I dealt with there has just been fantastic. I ended up having surgery just because I've got this genetic variant that was the best course of treatment. But as far as a center of excellence, I don't think you can do much better than UCSF from my experience.
And that's Carroll, Carrol?
Two L's.
2 L's. Okay, thank you again. Oh, thank you very much, you guys. I hate to take your whole meeting here, but I sure appreciate this being a first-time chatter. So this is very, very helpful.
I am also.
You had your hand up.
I'm sorry, did you call me or somebody else?
Yes, Norm, you had your hand up.
Yes. I'll just give you a little background.
We'll get to your situation in a bit here, but we have others in line. But if you wanted to make a comment specifically about Sandy's or ask him a question, that's fine. If not, we'll get to you in a little bit.
It's a new issue.
Okay, great. Rick, Bill Franklin is on board and wondered if you could make him a moderator as well.
Oh, yeah. I thought he was.
I was, but my system dropped me out for some reason.
Oh, okay. Ignacio, go right ahead, Ignacio.
Oh, just a quick comment. I'm also in San Jose, and just to add another endorsement for Dr. Carroll, because I
Okay.
see him as well.
Is he what sort of doctor is he? Is he a GU? Is he a radiation? What kind of
He's a surgeon.
surgeon?
He's a,
Okay, surgeon. Okay,
he,
thank you. Thank you.
he's a surgeon, and the issue really, he's a surgeon, but he does not push surgery. He's long in the tooth. He's one of the most venerable doctors there. If you wanted some sort of a second opinion on from your urologist, he would be the guy to go to. He's a little less opinionated than the Mac. So, seeing Peter and seeing Mac probably isn't a bad thing.
Right.
And he's going to have some thoughts on your crib reform, and he's also going to have some solid thoughts on your medical condition, even though he's only a surgeon and not an internist. And he's a good person, and you can tell him AnCan sent you, and he'll smile.
Oh, once again, very much. Now, see, my urologist is a surgeon, and he likes to do the Da Vinci robotic method, which he's talking up. You see, so surgeons like to do surgery. So I think I need a lot of opinions here, and I'm not going to take any more of your time.
Yeah, but that's what I'm saying to you. Carol is not a surgeon who pushes surgery.
Right. Thank you very much. All right. Well, I'll mute out of here and let you guys talk your other issues then. Thank you.
Well, please come back after you make some decisions before you have treatment. Share what your thoughts are with the group. Ignacio, so I would like to put you in the hot seat and get some information, and then we'll go ahead and have a discussion there. How old are you now?
No, you mean Norm. You said Ignacio.
Oh, Ignacio.
So you're talking to me now. Okay.
Yes.
My first time here, so I'm familiar with the format. I was in the hospital for a different issue when I saw a throwaway magazine, and it talked about this group and how wonderful it is. So I had a little trouble joining today. But anyway, my prostate history is that I'm 73, and for about 15, 20 years, I've had a very high PSA, which has been rather useless in evaluating me. It's been between 10 and 15. And so I had previous 2 biopsies about 10 years ago, which were negative. And when MRIs came in, I had a series of MRIs, all of which were negative, but just showed a gradually enlarging prostate. So more recently, I had a high PSA again. The urologist sent it for an assay to determine whether the high PSA was meaningful or not meaningful. Seemed to have come back saying was more meaningful. So we did another MRI, which just showed a massively enlarged prostate, and have had symptoms of enlarging prostate over the years. Then he did a biopsy, which was Gleason 6. Had 3 focuses, 2 on one side, 1 on the other, 3 different focuses. And then he sent that tissue for Oncotype, which is like a genetic assay to determine the significance of the Gleason 6, whether it was more dangerous to me or not. Seemed to come out in an unfavorable way. So the plan, after seeing the radiation oncologist, was to treat the obstructive symptoms first, and the prostate was way too big for a minor procedure. So I did have a robotic simple prostatectomy on December 2nd. And that was a little hard to recover from, but I'm better now. And I saw the urologist today, and he came out with a new test, the ArteraAI Postate Test. And that's a artificial intelligence analysis of the pathology, to go way above the regular pathologist to see whether my sample is significant or not, which supposedly has more meaning than the oncotype genetic analysis prognostically and should indicate what treatment or no treatment would be appropriate for me to either go ahead with the radiation about a month from now or not go ahead with it. So that's what I wanted to know. Has anybody heard of this or dealt with this new test?
So my only comment is that's not how I've seen it normally used. Artera has two products. One is the prediction about whether you have a benefit from adding in ADT or medication to lower testosterone after doing radiation. That's their one. The other is to look at the biopsy and determine whether you're a good candidate for active surveillance. I've not seen it used as a tool post prostatectomy, Norm. I wanted to get back. Where are you located?
I'm in Maryland. You know, I have access to Hopkins.
Okay. But again, I've not seen it. And I'm wondering if anybody has seen the Artera AI application after prostatectomy.
Well, the simple prostatectomy was really to treat the obstructive symptoms and not to treat the cancer. So, you know, I was told by the radiation oncologist that if you want to do anything regarding your obstructive symptoms, you got to get that done first. Because if we give you radiation first, you'll never be able to get surgery for that because it'll all be scarred down and it'll ruin all the anatomic borders, etc. So my understanding of it was this simple prostatectomy, which doesn't include the capsule, you know, where the cancer actually was biopsied. It's just kind of a coring out of the tissue, was simply to alleviate my obstructive symptoms, which it has done. Today, my post-grade residual today was 0.
We got it, Norm. We got it.
Okay.
The simple prostatectomy is another term, as I understand it, for a TURP. Some people call it a TURP. Some people call it a simple prostatectomy, but it's essentially a TURP.
Yeah,
coring out to clear. And I guess they're doing it robotically now, which is great. You know, the question. So really, this is not prior to a radical prostatectomy. This is prior to a radical prostatectomy. So maybe the Artera would be there. Are you seeing a doc at Hopkins right now or not?
No, I'm not. It's Chesapeake Urology, which has taken over.
Yes.
You know, large amount of them. Urology in my area.
Yeah. Who's the guy that's there? I can see his face. He does a lot of webinars, but I forget his name.
There's a million people there.
There's a million. But I'm trying to remember the name of this one guy. I see his face. He's kind of like a Neil Shaw clone, but I can't think of his name. So what specifically are you asking? What is the right test for you to be doing, or how do we assess the severity of your situation?
Well, I would go under active surveillance if I was considered at low risk, you know, of having metastases or dying from this particular issue if I didn't do radiation.
Okay, so have they
presented to me as another way of determining whether I need radiation or not? As today when I saw the urologist.
So what was the pathology after the TURP? Because they got tissue that they looked at. You said 3 Gleason 6s. That was a biopsy, not from the TURP, correct?
Well, the TURP revealed, I was told that all of the tissue was entirely negative for any pathology. So I guess a capsule remains, you know, which is what they biopsy, where most cancers are, to my understanding.
So the Artera would be a good approach to figure out how you might want to proceed. That makes good sense.
Okay, I wasn't familiar with it. I didn't know if anybody else had familiarity with it. You know, apparently it just came in 2024, and it's entered some guidelines as to use it.
Bill, we
And
will be
Medicare
very
pays for it.
interested in what the results turn out to be. If you could report back to us when you get them, because you
Yes.
know I think right now we're kind of don't want you to do very aggressive or even moderately aggressive treatment until we hear more information that justifies it. So we would love to hear back again and see how this turns out.
Okay, well, they told me I had to wait 3 months from the procedure for things to settle down before radiation was done anyway. So that decision doesn't have to be made until March.
Another thing that might be helpful, depending upon where the pathology was read, is in the chat window, you'll see an address for Dr. Ming.zhou at Mount Sinai, or you can contact the Johns Hopkins GU Pathology to get a second reading on it and confirm the Gleason 6. Frequently, if you're going to a community hospital, it's not going to be a person who's reading just biopsies from the prostate, and you want to get someone who really focuses on prostate biopsies. So with the time, that's something that I'd strongly consider as well.
Okay, I appreciate that.
Okay, let's. Anybody else have any comments for Norm?
And I was just going to reiterate what Mark said. To me, I think the most valuable thing that you can do right now is get that pathology reread outside of Chesapeake. I mean, my guess is the Chesapeake people are pretty good because they mostly they're referring a lot of urology stuff. They're very large. They may even have their own pathologist, but I would really get a good eye on that pathology and make sure they don't see anything. When was the 3+3 seen, Norm?
That was done, I believe, in November.
Okay, so that's recent. So
Yes.
you know, and I would agree with Dr. John and Dr. Mark that if we don't see anything from the tissue from the turp, and we don't see, and the other was 3+3, you might be wanting to join our active surveillance group, which meets every Wednesday. Our pre-treatment active surveillance group, and they will be stumped by your. They'll be stumped by your simple prostatectomy. They won't know that language. With a bit of luck, I might be there, but I don't usually get there till late. So you're going to have to explain to them that a simple prostatectomy is a turp, and there's a good chance they'll know what a turp is.
Yeah, well, the old term was turp. You know, not supposed to say partial. It's supposed to be simple. And
Yeah.
it was Dr. Harbin at Chesapeake who's done 1,200 of these in the last 10 years of the robotic, you know.
Okay, let's move on. We've got a couple more people who are in line here. Ignacio, you're up now, and we'll get a hold of your story here. How old are you?
I am 60. I've been here before, so I'm not sure. I mean,
okay.
I haven't heard my story, but I've been here.
Well, you wanted some time?
No.
No, I thought you had said. Okay, great. Okay, we'll move on then. Let's see here. The other new person is Dave S. I think it is. I'm trying to see here. Is there? I see Dave Begley.
Yes.
You in the group?
Yes.
Okay, great. How old are you?
66.
Okay, and where are you located? Huntington, West Virginia. Okay.
Yep.
And how did you get diagnosed, and how did you get here to the group?
Discovered the group on that Inspire website where you
Okay.
told somebody else to show up. So I coattailed on that.
Fantastic, great.
I
and how were you diagnosed with prostate cancer?
I had my annual physical last spring, and the PSA score was above 4. So the doctor referred me to a urologist. They did an MRI and found one Pi-RADS 4, if that makes sense.
Yes.
It was, the MRI was in preparation for a biopsy, which they then did at the beginning of August.
Okay. Does everybody know what Pi-RADS are when we refer to that? Basically, Pi-RAD is a score that they get by looking at the MRI, and they can look at the vascularity and the density of the lesion as it appears. And with each increasing number, it's more likely that there's a significant cancer being found. Usually less than 3, a biopsy isn't done. With a Pi-RADS score of 3, it's a small percentage that are going to have significant disease, and that increases with Pi-RADS 4 and Pi-RADS 5 lesions. So how many cores did they take on the biopsy?
They took 13. I'm not exactly sure how to categorize it. There was 13 samples, but sometimes there was like double cores or whatever. Is that
okay? And how many were positive?
They found 5 that were 3+3, and then 1 that was 3+4.
Okay, so when we look at the Gleason score, you can have it all over the place, but in terms of predicting the significance of it, the greatest concern is the one that's most advanced. So that would be the 3+4. Do you know what percentage of 4 was in that lesion?
Yeah, let's see. 40%.
So that's a fairly significant number. You have heard us talk before, I think, just about to everybody, that it's important to get a second opinion on the pathology by one of the leading experts. Do you know where the pathology slides were read? Was it at the local hospital, or did they send them off?
I thought it was the local hospital, but I'm not sure.
Okay, so it would be good to send to Johns Hopkins or ming.zhou. There's notes on that in the chat window.
It's not too late. It's not too late since it was already back in August.
The hospitals keep the biopsies that we do generally for 20 years.
Okay.
They can go back, and the tissue is embedded in a paraffin block, and either they ask to have it sliced before, or they send the whole block, and the lab will slice it, make slides, and send the block back to your hospital.
What we were going to do is just take some time to kind of think about it and watch it. But my PSA score went up to like 8 in October. And I actually have an appointment next week for another PSA test and to meet with the doctor. And he was sounding like he wanted to do another biopsy because with the PSA score going up, he thought they missed something, that there's more there than just the one.
Was the biopsy an MRI fusion biopsy?
It was the way he described it, the MRI guided where it went. So I don't know if that's a fusion or.
Yep.
So I'm just kind of trying to get ready for my meeting with them next week, just to kind of know, what people are thinking. And
Did they do any Decipher test or any biomarker testing on the pathology?
No.
That's something that I would ask about is what biomarkers could be done to evaluate this or determine whether additional biopsies are necessary. What other questions would people here suggest that they've asked the physician when he meets with them? Anybody have any comments?
Yeah, I mean,
Ignacio, go ahead.
You're muted, Ignacio.
My apologies, I was on mute. A couple comments. The first one is that the PSA are doubling in such a short period of time. That's actually called PSA Velocity. That usually does not portend well. However, if the 3+4 that they found was not part of the Pi-RADS 5, that could be interpreted as a good news, because MRI in invisible lesions tend to not grow. So what I would ask primarily is about PSA velocity, and in second place, I would ask if the 3+4 was part of the Pi-RADS 4 that they targeted, and you certainly hope the answer is no. In my case, I actually have a Pi-RADS 4 and a Pi-RADS 5. And also Gleason Score 3 of a 3+4, but I'm fortunate in that my 3+4 turned out to be, my Pi-RADS 4 turned out to not contain any cancerous cells, and my Pi-RADS 5 contained 3+3. In other words, my 3+4 is outside of the Pi-RADS lesions.
Okay.
Rick, you're up next. Rick.
Got it. Sorry. This is, forgive me. This is puzzling because with the type of prostate cancer that we saw back in August, it's unusual for it to move that quickly. It's really a puzzle. So my first thinking is something else is going on that is not the cancer. And what I've been doing is digging down with the urologist or a urologist about what else might have caused a jump. Because if they did an MRI fusion and they didn't see anything before, for something to come up that quickly in 4 months is unusual.
Okay.
Because prostate cancer grows slowly. So that's the first thing. What that leads me to is whatever this guy tells you, I'd get a second opinion.
Okay.
Because it sounds like maybe they didn't see everything or do everything right the first time. It's possible that these were there and he didn't see it. So I think you certainly need at least one more opinion, and preferably from a center of excellence, which ain't easy in West Virginia because you got to travel. And I would say probably go to Hopkins or Penn, are probably the two closest. There's actually you can actually use Sibley in DC or Baltimore. We can give you names of good docs to see at both. Well, we can certainly give you names at in Baltimore. and I think some of them may also practice in DC at Sibley. So, and for sure, you might want to get the slides reread, the old slides. I'd be interested to know in this group, because you deal with biopsies a lot more than we do in the advanced group, but how often anybody's come across having to do a biopsy 4 months after they last did a biopsy. It's unusual. It's really unusual, Dave.
Okay.
And I just also want to say, Stuart, I know where you're going, and it's a great suggestion, but I'm going to put another link underneath yours, because when we refer people to Promise, and please make a note of this for this site is tagged to us. So the Promise people know how many people are coming from the AnCan group. And you, Mr. Jordan, understand that. I know you understand that part. So I'm gonna put the Promise the AnCan Promise link in right underneath, and maybe you'll make a note of it. Go ahead. You go ahead, Stuart.
Stuart, you're up.
No, I was just going to say, both for Dave and also Sandy, I'm not sure for Norm whether it makes sense that the Promise study, which is the genetic testing, could be helpful in terms of identifying the need for treatment. And I don't know how to, Rick, I don't know how to delete my link.
No,
I would, but please post it, because I have to send it to two people.
Okay. Okay. No, that's the wrong one.
And Rick, I have a request. After you're done posting that, we mentioned the survey early on.
Yes.
And it would be real helpful if you can post that. And anybody who hasn't taken the 10 minutes to complete the survey about AnCan and your experience, we would really appreciate that as well. I wanted to ask Dr. John or Bill, do you have any comments here for Dave?
No, I was going to say something along the lines of what Rick said. It's unusual for a PSA to get an additional biopsy that quickly after the first one. I mean, there's lots of things that can raise PSA, but I don't know by a point count of 4. If you've been in the meetings before, you've heard people talk about having sex within 72 hours of a PSA test can make the score a little bit higher, or riding a bicycle, or one of our moderators claimed that riding his Harley for like going on a road tour raised his PSA. So I guess that'd be similar to a bicycle ride. I don't know. Not as strenuous on the legs, maybe, but yeah. But maybe Mark, maybe you could comment on how high would like sex or bicycle riding or one of the other things that they talk about possibly great. Would it be 4 points? That seems excessive.
Certainly not in this order, and certainly not switching diet or taking febendazole or any of those other things that you might see on the internet as definite cures for cancer would play a role like that. So that's something that an acute prostatitis or an infection after the first biopsy potentially could hang around and cause that kind of rise. But otherwise, I would not. That's the only thing that I could think that might reasonably cause that kind of rise would be infection.
I have a quick question, if I may interject here. Did I hear that your the 3 + 4 was 40%? It showed on your biopsy. Did I hear that right?
Yeah, the portion that was 4 was 40%.
40%. Okay. I had 15% with the letters LLM on one of them, the 3+4s, and the other was 4% with the letters RMM. My question to you or anyone else is, what do those letters mean? Does anyone know?
Location on the prostate.
Location?
Yeah.
Ah, okay, like middle and right
Yeah.
side. Oh, okay. Thank you so much. Sorry to interject there.
Okay, Sandy, just for the future, there is a hand function at the bottom. You can raise your hand. I think it says react right at the bottom.
Oh, I'm sorry. Okay, I'm
And
new.
then we know, and then we will get to you. Okay?
Interrupting.
It's
Well,
fine. It's a newbie mistake, and it's perfectly okay.
And I've made it. Okay, guys, I'm going to remute. Thank you again.
Okay,
And always ask questions. If you're a new guy, and we start throwing around terms that are unclear, we don't want you to get lost. So definitely ask.
Now, my prostate, the biopsy had all the locations, and then it had one that said ROI1. Is that the spot that had the Pi-RADS maybe, or is that just? They all say left, mid, right, all that stuff, and then one says ROI1.
It is possible that your hunch is right. That may refer to the location pointed out by the MRI, but I can't really think of what ROI might have.
Okay, I'll ask him when I'm there.
Yeah.
Because that was a 3+.
I bet you're right. I bet it's something that was not part of the standard 12, but one of the add-ons. But I don't know.
Okay. Because that was
Stuart?
that was a 3+.
Yeah.
So.
Our ROI is region of interest, and
There you go.
And that is the sign of the fusion target.
Okay, and that was a 3+3, so it wasn't a 3+4.
Thank you, Stuart. That means the region of interest was a very low-grade prostate cancer that the MRI was picking up.
Okay.
It kind of refers back to Stuart's other point about invisible lesions.
We have some newbies here. If you are not yet signed up for emails, you can put your email in the chat, and Rick will make sure that you get emails about upcoming sessions and reminders. And those email reminders are filled with a lot of interesting information about things that may or may not be relevant to you in the future, but at least you'll know what's going on. So if you haven't gone to the website and signed up, you can put your email in the chat window, and we'll make sure that you're kept up to date. Paul, you're up.
Hold on a minute. First of all, if you don't want to put it in publicly, and I now have Mr. Begley's, so it's there, but you can send it to me.
Oh, okay.
Underneath the message, it says everyone, or if you click that arrow, you can pick who you want to send your message to. So if you don't want it to go private, that's fine. But a lot of people like to put their emails in because people will respond to you. They want to talk to you afterwards. We did a survey in 2021, and we discovered that 43% of people reached out to other participants outside the group, and 30% made friends, like Corsley and Boykin, which is a perfect example, which really warms my heart. You're very free to send it to me directly, and we'll make sure you get in if you want to receive a reminder each week. This week's reminder in particular was excellent for the low intermediate. It detailed 10 or 15 myths about prostate cancer that Dr. Mark put together. Really, really good. There were certain people in this group who wrote some congratulations. If you would like to get that and you didn't get it, put a note in the chat. We'll make sure that you receive that. Since I have the floor, I'll say a couple of little things, and then we'll go on to Paul. The survey that we're doing now is an update on that survey from 2021, except we're doing it across the whole of AnCan. We weren't as big. We didn't have as many groups. We were mostly prostate. Today, we're about 50% prostate. Some of you may know that we have some great mental health programming, which we can sign you up for. Dr. John is one of the moderators. We address anything that's on your mind except treatment. And you'd be surprised what is on a lot of people's minds. And they are very, that group is really an outstanding group. I have to say, we meet twice a month. Secondly, I just wanted to say a quick word about the fundraisers. This is not for the newbies. This is for the people who have been around for a while. We kind of been a little disappointed at the response to our fundraiser this year in terms of the percentage of people that have donated. I think the number from low intermediate, and there is some crossover, is something like about 6% or 7%. It was in your reminder. You can see it. I think it was 6%. That means that 1 in 16 people that gets our reminder is donating. And we know we're making a difference for you. We know how important these groups are. And we also thank all the people who are in this room right now who have made a donation already. And there are a number of you, but there are a number who haven't. It does matter how much, but even the smallest donation signals to us that there's some gratitude and that we're not taken for granted. And that's really important for us. I have to tell you. You know, for the price of a latte at Starbucks, you could be giving us $100 a year. And even if you give us 50 or 25, at least we know we're making a difference for you. And we need that to keep our lights on. So if you haven't donated yet this year, you'll be getting another email. If you have, you'll be getting a thank you email. And we just ask you to just consider us kindly. And just a message for Louis, Louis, I'd be happy to, but I don't know if I have your email. If I have your email and I know your last name, I can send it to you, but it's a bit hard.
You do have my email, and
I do.
You thanked me for my contribution.
Okay, give me a clue on. Okay, I think I can figure it out. Then give me a clue. What's the first letter of your last name?
Rappaport.
Oh, got it. Okay, sir. Thank you very much. And yes, I'll send it to you right now.
Okay.
I'm done. Go ahead.
I just wanted to comment on one thing you were saying about getting together warms your heart. Last week, Jose and I got together and met for brunch. And I think it was the very next day or 2 days later, about a block away from where we met, one of the houses in Studio City caught fire and rolled down the hillside. Luckily, it didn't cross Ventura, but it was darn close to where we were. So our heart was warmed indirectly by this conflagration. I made a small note about that in the chat window. Paul N., you are up. Thanks for hanging around and waiting for us.
No problem. I was entertained by all the above. Let's spoke there. All right, so just a quick status. I just completed today my 28-day external radiation treatment. So let's see. Obviously, if you guys whoever went through these experiments, it's really literally painless and rather quick. I mean, I'm on the table for less than 7 minutes, pretty much. It's just matter of logistic and prepping for it. The whole thing with empty bowel and full bladder took a while for me to get the routine. So I'm done with that. So the next step will be 3 month PSA test, follow a week later with a consult with one of the radiation oncologists. And we'll go from there. Hopefully it'll start trending down as expected. Side effects, the expected, started out with some rectal bleeding. So I was a little bit concerned about, what is it, proctitis. But they put me on a suppository, and that seemed to be resolved now. And we'll see if the midterm, long-term side effects appear. Hopefully, not. And then the other one is the other expected one: urinary issue, incontinence, urgency, unable to complete, all the above. But they all pretty much managed. So hopefully, all these will start winding down. As the time goes on with post-treatment. So that's the report I have. So I wanted to get the SBRT to 5 day, but my oncologist said, no, don't recommend it because my tumor was too close to the urethra. And I kind of confirmed that by taking the Prostate test, which confirmed that I'm not a good candidate for the shorter, high intensity treatment. Better off with the longer term one. So, okay, so that's why I am.
Paul, do you know what machine they used? And did they talk to you about one of the gels?
Oh, I did have I did have the Barrigel, as well as of course, the judicial markers. So initially, when I started my rectal bleeding started right at the end of the first 2 weeks. Second week, it started kicking in. So the doctor was surprised because that's really not expected that soon. It's more normal to expect it later on the treatment or post treatment. So I actually talked to 3 oncologists that they were rotating around. They'd have a weekly consult during the treatment. So, and then none were really concerned, and it turned out they were right. It's probably due to maybe a little flare up because I had a history of hemorrhoids, constipation and hemorrhoids, so that probably flared that up. But right now, they say it's got improved well greatly. So, and then the machine is the variant. I forgot the name of that. It's not an MRI guided one.
Okay.
Yeah. The facility in Northern Virginia did not have that machine in place.
And Paul, I'd just like to say a big congratulations. This has been a long journey.
Yes, it has.
I would guess that you've been making this decision, I'm just guessing, 18 months to 2 years. Is that about right?
Actually, you still a few months off. Actually, pretty much a little bit over a year. So let's see how it's diagnosed.
A little bit over a year. But we've been seeing you for a long time. Keep coming, as you know.
Yeah.
Go show your face in the active surveillance group because they'll be pleased to see you, and tell them that you've done your treatment, because they always like to know what's happened, and they'll like to hear that you're doing well. And keep coming back, man.
Yeah, thanks. I mean, I wrote that active surveillance bus for a year. Listening to you, the guys in there, and yourself included, Rick. You learn a lot. And, it was
right.
Fortunate that I had that 1 year to learn a lot and make a final decision. Right? Even though I stepped out of line a few times, and you put me right back in my place a few times. So.
Yeah, you won't let me forget that, will you?
No, no.
Any
Well,
other
whenever we do have a
comments
chance to
here?
meet. No,
We
no.
do it. We do it with love. You have to
That's
understand that.
right.
Right,
Rick and I have a thing together. It's a private
right.
thing.
Mr. Franklin will tell you we do it with love, right, Mr. Franklin?
Is that what you call it, Rick? Yeah, Paul, I was going to say that, yeah, I've been there, same treatment, basically. If you got any questions, just drop me a line. I'll be happy to talk to you, especially on
You
the
talking about
recovery
Rick
side.
or the radiation treatment?
Yeah, I had it all: prostatectomy, radiation,
Oh, okay. I just said
hormone
just the
hormone
radiation.
deprivation. I've had all
Oh,
the
no, no.
treatments. Anybody wants to talk about them, let me know.
You're the encyclopedia. All right, thanks.
Anybody else have any comments for Paul or questions? Okay, next up, Stuart, you were on the list. Did we get to your comment, or did you still have something for us?
Now I have a couple of quick questions, and actually it's for my brother, who he had a Pi-RADS 4 MRI in December, and he had biopsy last week and got biopsy results today. He has 2 3+3s, and he also has 2 areas of ASAP, I guess it is. And so, a couple of quick questions. On 3+3s, does it make sense to be doing a Decipher test?
Anybody want to respond to that?
I would say yes if your insurance covers it.
Jim Stewart.
Yeah, I'd say it's definitely wise to do that. And I think any kind of genetic testing is crucial because it changed my entire course of treatment, and I think made a huge difference in my outcome. And so I would say, to answer your question, yes, definitely, in my opinion.
For 3+3, because I have 3+4, and we definitely did it, and it did have an impact. But I wasn't sure for 3+3.
Yeah, I was 3+3, and had an idea that I had the genetic variant before that, but they did a more detailed DNA test at that point and confirmed that I did have the variant, like I said, at 3+3. And then my second biopsy was 8 months later, and it had progressed to 3.7 to 3+4 by that time. So I would say yes.
Okay, great. And Rick, if you've got the other link for Promise, because I want him to do the Promise test as well.
It's right under the link that you put in, I think. I thought I put it in.
It's just the survey's there.
The survey, and then, wait a minute. I know I put it in. I don't understand. It is weird because I don't see your link either. Both of them. Yeah, both of those things got removed. How weird is that? Oh, no, there it is. Ah, okay. I know what I did. Sorry. Who did I send it to? Oh, I sent it to Jose. Sorry.
Yeah.
I meant to send it to everybody, and I sent it just to Jose. That's what's going on. All right. Okay. It's coming to everybody right now. Thanks for picking that up, Stuart.
And so, Mark, my other question about the 3+3s is, it was my impression that at this point, 3+3s are pretty much surveillance. Are there instances where 3+3s would require treatment?
Well, first of all, I think it's important that, we're like a broken record, that he gets a second opinion on the path. I think the PROMISE study, that can be done with 3+3s. And I think that that's something that would be valuable. Also, Decipher, and then putting all that information together, probably the majority of the people would come up as a active surveillance. Do you know how many cores were done and how many were positive?
Two positive out of 13. And it's weird because the report only reports 30%. It says 30%, but which is one of the two. It doesn't have a percentage on the other one. And the other interesting thing is that the Pi-RADS 4 that prompted all this was benign, and that the 2 3+3s that they found, which are on each side, one on the left, one on the right, were both part of the random.
So that's, that's one of the arguments and one of the controversies. But many physicians will say that the significance and the risk of disease progressing that's invisible on an MRI is quite low. Other people say, well, it's 6 to 7%, and you might want to do it. But I think that most people now are coming down to say the invisible lesions don't really pose much risk. Worst case is it would progress and you would follow up and do another biopsy or treat it. I don't think anybody would be worse for the wear, but if it turns out that there's a repair mutation, then that might be something that might cause you to be more aggressive earlier on. So I think a little bit more needs to be done to look at this. And then I think he's probably going to be in active surveillance and quite comfortable with that.
Great, thank you.
Yeah, and Stuart, first of all, I'd really encourage him to join the active surveillance group because it's great support, especially if he's at all anxious about the diagnosis. Secondly, some of you know Eric M. from Atlanta. He has 11 out of 12 cores that are positive, but they're all 3+3, and the consensus is he still continues with his active surveillance, watching very carefully. So I think he's a really good poster boy for how you deal with 3+3s.
Okay, Sandy, you have your hand up.
Yes, I'm actually following procedure now, Mark. Thank you. Maybe a naive question. Would it make sense for me to ask for genetic testing at this stage, since I've already had the biopsy, but I haven't had the MRI or the PET? I've just had the basic CT. And here's the second question that is naive. Is it from the biopsy material they took on the core, or is it a blood test?
Okay, so that's a great question. There are two types of tests. One, they actually look at the tissue, and that would be Decipher or Oncotype or something like that. That's Decipher, and that's done from the biopsy, and they need the tissue. That's not something they do off of looking at the report. Okay. The other is to see whether you have a mutation in any of the cells or every cell in your body. Those are called germline mutations. We got them from one of our parents, or is a new mutation, but it's not just in the tumor, it's in every cell. That's done from a cheek swab. And the nice thing about the PROMISE study is you don't need a physician's order to do it. And they mail you the kit, you send it back, it gets done. I think you need a doc to say who gets the results. But that's easy enough to do and well worth doing if you have any cancer on the diagnosis.
Excellent. Well, thank you. Do you know if insurance will cover all these tests, these genetic things? I've had problems.
Well, again, the PROMISE is free.
Oh, okay. Yeah. Okay. Very good.
And Decipher should be covered.
Uh-huh.
I would think that it would be covered.
Okay. Very
John,
good.
you have your hand up?
Yeah, I just wanted to pick up on somebody, I think Stuart mentioned ASAP, just to say what it was. And a person with ASAP on their biopsy who also has 3+3 prostate cancer doesn't really have to do anything about the ASAP, because the surveillance done for the 3+3 prostate cancer will also take care of precancerous lesions like ASAP or high-grade PIN. So that's not really of too much of a concern.
Okay, great. Bill?
Yeah, I was just going to say, Sandy, I'm no longer my primary care physician, but she was. But the group she was in stopped taking my insurance. But anyway, I was fairly close with her. She was a student of my wife, so we knew each other very well. So, but she told me that for insurance purposes, for genetic testing, if you tell your primary care physician that mother, father, any of your grandparents had cancer, then you have a family history and it's medically necessary.
Okay. Okay. Yeah, because I've when I had my myelodysplasia, which I have, I had to have genetic testing with my brother to see if he was a match for a stem cell transplant, which fortunately I never needed, but that was big money. And at that time, I wasn't on Medicare. I am on Medicare with Health Net, so hopefully that's good information to let them know it's a family history. Then, thank you.
Does your MDS take away, I mean, are you anemic? Do you have fatigue from it or any frequent infections, anything like that?
No, no, it's stage 0 to 1, they call it. I've had it
Okay.
since 20, oh gosh, 14 or something. And
Oh,
could, of course, go to leukemia and all that. But right now it's the platelets and has been the platelets. I've had to have transfusions when it's down around 20, 30K. But the last couple of years it's been 70 to 90. So, I think it's steady as she goes, but at any
mhm.
time, that's one of my pre-existing that concerns me with, of course, surgery. So
Yeah. So you're probably getting a blood count every 3 or 6 months or
every three
something?
months or six
Yeah.
months, yeah, CBC, and it's okay, But while I got everyone online, if I had radiation, could I have surgery later if needed, or is that precluded? It ruins a lot of the tissue. Another
So
unrelated question.
you wouldn't need surgery.
Hmm.
If should there be recurrence, you have the ability now with modern radiation to be retreated, or if a lesion shows up on PET scan, address it with focal treatment, one of the myriad of focal methodologies that are out there.
Okay.
Um, there's no point where I think in your situation it might be advisable, except if you found from BPH that you were having to catheterize yourself,
Right.
then the surgery potentially makes sense. But other than that, I think you're a good candidate to stay as far away. As a surgeon, I think you're a good candidate to stay away as far as you can
Yep.
from an
You got it.
operating room.
That's kind of what I'm concluding. Okay. Thanks again, guys. I'll mute, and thank you once again. I'll be on the next meeting, I'm sure.
Okay,
Have a
great. Stephen from Vancouver, you're up.
Okay, thank you. I guess it was a month ago that I spoke and sort of detailed where things were at. Do you want me to give a history or just sort of do an
If you
update?
can briefly catch us up and then give us an
Yeah.
update.
Okay, I'm 73, so 4 years ago is with a PSA of 5.3, sent to a urologist to, strangely enough, he said, well, we can either do an MRI or we can do a biopsy. What do you want? And I didn't know anything at the time, but I thought that it made sense to do an MRI, which subsequently I learned that of course that makes sense. And then from that they did a targeted biopsy, and they found 1.133 and two areas of 3.4. And I've only recently did a second opinion with Dr. Zhou on that, and it was pretty much went along with the first one. He may have taken down the percentage a little bit. I think his percentage was maybe 10% of the 4. And the first one, and they did find some interductal, which I know is concerning. So I'm in Canada, and I just seems like the options that you have covered through Medicare are a lot less than what I'm finding with people in the U.S. and maybe elsewhere as far as choices of treatment. Make a long story short, they in Canada they would offer me surgery, which I didn't want to do, or they offered me the recommendation has been the seeds, the brachytherapy. But knowing that there might be other possibilities out there, I did reach out to Dr. Mark Schultz, and I have to say that him and his associate, Dr. Lamb, were the best conversations I've had. The conversations in Canada are always very short, and so I find, even though I'm paying for that out of pocket, I at least felt I was really being heard and getting some good suggestions. They both thought that because my cancer is all those 3 areas are all on one side, on one lobe, they thought that I was a candidate for focal. And Dr. Schultz, with my large size prostate, thought that he recommended a fellow who works in the sort of South Bay area. He works at a lot of different centers, and his name is Dr. Stephen Kirksman, doing brachytherapy for a number of years. He's done thousands and thousands, and he's, I guess, beginning to do this focal brachy. So that's what he suggested, is focal brachy to the one side, and that to me kind of seems promising, because it's maybe cuts down on side effects. So he wanted an updated MRI. I've had yearly MRIs, and they haven't shown any development on the other side. So, but he wants to get one recent one before we go ahead with this procedure. So there's a waiting list up here in Canada. Well, there'd be a huge waiting list if I wanted to get it for free, but if I wanted to pay, there's even a waiting list. But I'd plan on taking a trip down to Puerto Vallarta, take a little break from all the rain and everything we get up here in Vancouver, Canada. And so I've been looking into talking to somebody there, and they can put me in touch with getting probably the contrast dye MRI there in Puerto Vallarta, which will also save a bit of money. So that's the plan. Is in the next few weeks I'll have the updated MRI, and if things still show that there's no areas of concern on the other side, then I'm planning on going ahead with focal brachy, which I guess is more of a recent approach.
I'm curious as to what their recommendations for treatment were, and did you have the discussion on active surveillance versus treatment, and what led you in one direction or another?
Yeah. I've never really had any support actually for active surveillance here up in Canada. But have never had a doctor that's really been, I feel like, on side, which is why I sort of reach out to the States. What's prompted me to look at treatment is the fact that the MRIs have been showing a growth of the main tumor from an initial 6 millimeters 4 years ago now to maybe 1.2, and it's grown, so it's now abutting the prostate wall, and that, I don't know, to me that sounds like you're starting to run a risk there, and so that was what's prompted me to go for some treatment. Dr. Schultz also suggested the Oncotype test, which I guess would show the aggressiveness of the cancer and would maybe help in sort of saying just how fast I needed to work on this. But my tissue was too old when I took a bit of a process to finally get a hold of the Oncotype people, because I was given a wrong number. But when I finally did get a hold of them, it turns out my tissue is too old for them to do that test. So
if I'm correct, you said earlier that you did have cribriform pattern on the biopsy.
That was cribriform was put in there, and then the Dr. Zhou didn't use the term cribriform; he used the term intraductal.
Okay.
I'm wondering, Rick, if you have any thoughts about
I
treatment with.
Yes,
that.
I do. I look. I ain't a doc, but if it was me, I would never, ever do focal treatment with cribriform intraductal. And I am just, I'm floored that Dr. Schultz and Dr. Lamb recommended it, but I guess I'm not surprised because Dr. Schultz is very much a do no harm doc. But the likelihood that you're going to have to go through something else within a pretty short period of time is very high. If you are going to do that treatment, do the whole gland. I would do the whole gland. How much 4 do you have, Stephen?
About 10%.
Of how many cores?
On 2 cores.
And where are those cores?
All on the left side.
Mid or lateral?
I think I can pull up my biopsy here in a second, but I think one was well, I'll just grab it here.
Look, here's the issue. I'm asking you because if the disease is all on one edge of the prostate, maybe you can get away with focal treatment on half the gland. But the cancer doesn't have boundaries. So it moves all over. And if you've got intraductal cribriform, the likelihood is that some of those cells, even though they can't be seen on a biopsy or on an MRI, have moved throughout the gland. And what's going to happen is that a year or 18 months from now, your PSA is going to start climbing, and we're going to look, and it's going to be cribriform intraductal, and who knows where else it's gone. And I mean, to me, it's insane that they suggest to you that you do a focal treatment with intraductal cribriform, because that immediately makes you high risk, not low or intermediate. It moves you up, and you don't do focal with high risk. If you had 3+4 without the intraductal cribriform, maybe, but you're still faced with a 50% recurrence. With intraductal cribriform, my guess is that is way, way higher. And and Schultz and Lamb charge a lot of money. I wish you'd given us a fraction of what you give them, because the advice that you get here is equally as good, if not better, in my view, from peers. And I wouldn't dream of it, because otherwise we're going to see you back here in a short period of time, but you'll be in the advanced group, and you'll be like the guys in the advanced group who did focal treatment, and they come back a year or 2 years later, like Julian M. in Houston and other guys that we've got, and they say, well, what do we do now? It's crazy. Dr. Mark.
Well, I'll tell. I've got my biopsy. So the 2 areas were left base medial and left base lateral are the 2 areas of 3+4.
Okay, so the medial means it's not in. It's it's in the center of the body. It's in the center. So I don't know where they're going to design. And focal therapy, focal brachy is the oldest focal technique, because they can put seeds. They can put seeds in your prostate where they want to put the seeds. so they can treat where they want to treat. I mean, I've got, I don't know, 54 seeds in my prostate, which was the whole of the prostate. But sometimes they'll put 70, 80 seeds in, but I was getting additional radiation on top of that. But there's nothing new to focal brachy if they're using seeds, and if they're doing focal brachy with high dose, which they could be doing, treat the whole gland, man. It's not going to. I don't think it's going to make a huge difference in terms of side effects. That's my own personal opinion. You're going to have the side effects either way. But what you don't want to do is have to deal with this again in 18 months. Mark, why don't you?
No, I know that. You know, a month ago, when I talked with you guys, you brought this when I did have a second brief conversation with Dr. Schultz. I did bring this up. I said I was in a meeting, and people expressed, you know, some concern about the with this introductal being a problem, and I brought that up to him. He didn't seem to be bothered by it.
So
he should be. He should be. I mean, hold on a minute, Mark. He should be. If he's not, I mean, we have a we have a recent UCSF forum where they discussed introductal and crib reform, and I'll send it to you. And do me a favor, you send it on to Dr. Schultz. And if I see Dr. Schultz, which I may well do at GU ASCO, I'm going to say to him, Dr. Schultz, why do you not seem to have a problem with introductal and crib reform? He's living in another century. I'll put the link for the crib reform in there. It was actually spotted by one of our advanced guys, and it's a good piece. Dr. John, you looked at that piece, didn't you, on the introductal and the crib reform? You're muted, John.
Sorry, guys. I was still muted. Couldn't find it. Yeah. It's not a good time to be very, very conservative when you have that pathology.
Unbelievable.
My thoughts would be that if you're doing something and making a decision to do less than what has been shown to be effective, you want to have good evidence that it's going to reduce the side effects or lower your risk. Because no matter what we do, we always want to make a risk-benefit analysis. And I'm aware of no information that would say, I mean, it makes sense, and it's a good supposition that if you're treating less of the gland, you will have less side effects. The problem is that there's no data to support that you're less likely. You're still going to go through anesthesia. You still put yourself at risk for GU problems. There's still a possibility of infection or bleeding or what have you. I just don't see that going focal on a disease that has a high risk of recurrence without data that says, you know, we've cut our side effects in half, or we've had a significant reduction. So and Schultz is my doc. I'm glad that I'm not in that situation right now, because that doesn't seem like the standard in our basic understanding at this point on that pathology. Anybody else? Sandy, you have your hands up.
Yes, Stephen, the doctor I'm going to see on the 23rd is Dr. Stephen Kurtzman. I put my email on the chat. If you
okay. Okay.
When is your appointment with him?
Well, my first step is to get this MRI to make sure the right side is still clear, and then we'll set up an appointment.
Okay, we can talk offline on that if you'd like to pick up my email and rather than waste time here. But very concerning what was just discussed. So okay, thank you.
You see, the problem, Stephen, is it's impossible to tell you that the right side is clear. They can tell you there aren't enough cells that are gathered together in one spot to show up. They don't see anything. But because you don't see anything doesn't mean it's clear. And if you're going to treat a part of the gland and there was something there, it's going to come back. And when you have intraductal and cribriform, which is nasty disease, and they can't see it on that side of the gland, but it's in your prostate, encapsulated in your prostate, I don't know how much faith I would put in an MRI that tells me they don't see anything on the MRI. Who's doing the MRI?
Well, I've been getting yearly MRIs up here at the same.
And how many Teslas is that machine?
I'm not sure. Is 1.5 the?
Yes, and 1.5 is an old machine, and if you're going to do it, you better get a 3 Tesla at minimum, and there's even more than 3 Tesla. You heard it here first, man. This is what we're about. This is what we're about here. We're trying to guide you to the best thing. If you want to rely on a new MRI, make sure you get the most up-to-date MRI. You're going to be spending all that money going down to Puerto Vallarta, and then you're going to have to be going back down there again in 12 months' time.
Well, I'm going to go down there anyways, but I will check on the Tesla machine that they have there. And if it's not, doesn't meet the requirements. I just saw the 1.5 because I've seen that online. I'm not sure what the ones here in Vancouver are. I assume that they are fairly up to date.
Don't assume anything.
Yeah.
Rick, let's move on because we do have a few more people who didn't get to check in initially that I want to run through.
Thank you, guys.
And say, let us know how things go. Enjoy Puerto Vallarta. Get to see Vedanta and the new Cirque du Soleil setup at Vedanta in Puerto Vallarta. It's going to be amazing. Tim, do you need any time tonight?
No, I'm good.
Okay, Lewis, are you going to want some time tonight?
I'll just give you a quick update. I'm still vacillating, and I know the consensus here is focal therapy is not great, and that was echoed by a radiology oncologist that I met with the other day. But I'm still vacillating between the two. I did get a Decipher report that was one of the few positives I've encountered throughout my short history. I was classified with a low risk. 5-year was 0.7%, 10-year 1.8%, and 15-year 1.6%. So that sounded good. I'm having on Wednesday, I'm going for the PET scan. Then I'm meeting, based upon conversation last time, the radiology oncologist that I spoke with the other day, and for want of a better word, my experience so far is that the doctors that I'm meeting with tend to have a bias with their specialty. This doctor was a proponent of proton radiation as opposed to photon radiation. Spent a good portion of time with her, went over questions and answers. A couple of people the last time mentioned Dr. Nagar, so I'm going to be meeting with him on January 24th, and then with a second urologist at Sloan Kettering on the 30th before I make my decision.
My comments on proton versus photon. There are a couple of things. One, the margins that are added around the tumor are almost twice as large with proton. So they talk about the Bragg effect, that you're delivering more energy directly to the spot. The problem with that is the spot is now enlarged 3 to 5 millimeters to cover movement Proton does not correct for movement in the prostate. If there's a gas bubble through the rectum, or bowel is moving, or the bladder fills. There's no adaptive therapy with proton. And sorry here. You don't have gating on the proton machine to stop the beam if things should move out of the field.
Apparently, the use of the proton therapy, notwithstanding Dr. Yaqub's commentary and her specialty, and there are only 2 machines in the metropolitan New York area that do that, which is why I guess I'm meeting with Dr. Nagar. Well, seemingly the procedure is controversial, and the end result not too much different between the 2 procedures. She did say that I was a candidate for the 5-day SBRT, either proton or photon. But one area of concern that I have is that one of the lesions is apparently close to the urethra. So,
well, I think that the Electa machine at MSK is far more precise. Particle, PARTIQOL study, which was a randomized study comparing, again, not with the Electa machine, but with the standard IMRT versus proton IMRT, showed no benefit to the group that got proton. Dr. Rossi in San Diego does about as much proton work as anybody, and he found a lot more skin burns with proton SBRT than with regular SBRT. So the question is, if you're dumping all the energy just into the prostate because of the Bragg effect, why are you getting skin burns? Yeah. And it may have to do with the proton, the beam. You have 2 paths for all the energy coming in. With MRI, there's 15 paths. If you use a Varian Edge machine, it's an infinite number of paths as the table and the machine rotate to compensate for any movement. So the one thing proton has going for it is the best marketing in the world. It just doesn't have statistics to show any benefit, whether it's for SBRT or for IMRT. Just experience. Anybody else have any comments for Lewis?
Yeah, a study that was done a long time ago determined that proton tended to have higher comorbidities in the GI region and photon in the GU region. And that's still a more recent study that just published, and Dr. Mark will know it, finally published, also seemed to somewhat support that, although there's not a heck of a lot of difference. My problem in talking to the radoncs that push proton is that oftentimes they're proselytizers. And I know that Dr. Nagar is at a center of excellence. Is the other doc at a center of excellence too?
Yeah. And when I mentioned Dr. Nagar to her, she referred me to him. So I'm going to meet with him on the 24th.
Yeah. I think he uses both. And Dr. Mark knows Dr. Nagar. So I think he's going to be a real good guide for you. And
then is the ultimate question for me is focal therapy versus radiation, both of which have their downsides.
Well, like I say, there's a lot of risk in focal. Again, I'm not sure of your stats, but you've heard what I had to say. I ain't going to repeat it. Oh, and speaking of, yes, Stephen saw my post. I wanted to make sure he saw my post. Okay, I'm not going to email it to you as well, Stephen. Watch that. it's enlightening, shall we say.
Oh, yeah, just briefly, my stats, I mentioned the Decipher study, having the PET scan on Wednesday, and I was a 3+4 on the Gleason scale, and the 4 was 5%. So everybody tells me it's treatable and rather on the low side.
What have you ruled out active surveillance?
Yeah.
Because?
My mindset is that, I want to have it treated and hopefully cured and not live with it.
Okay. It's not going to be cured. And don't let anybody tell you it's going to be cured.
Well,
the best you'll do is what the venerable Dr. Snuffy Myers, God rest his soul, calls a durable, continuing remission. But if you've got a 4 in your number, we don't have the technology to cure it. And the docs, even the medical oncologists, and I've heard them say cure, and you challenge them, they say, well, yeah, you're right.
Well, there's always the chance that it comes back either with radiology or with this focal therapy.
Okay, but that's not a cure.
Yeah.
A cure means it's gone.
I know.
And that's why we are very careful with our language here. In fact, Dr. Mark and I had a little discussion about this, and we're going to revisit it soon, but you've got to be real careful about how you use that word cure. So I don't know that a cure is in sight. I would say to you, try attending the active surveillance group and listen to them. And maybe we can give you enough support and comfort, because frankly, if you can get away without treatment and you don't run a risk of the disease getting worse, which we truly believe you don't if you are the right candidate, active surveillance is the way to go.
Yeah.
And you've got a bunch of guys on here who've been playing around with active surveillance for a long time. Would one of them, who happens to be in Canada, like to speak up on that?
Well, yeah, sure.
Could you give Lewis
I'll go for the bait.
a little comfort on that, Joe?
Yeah, I've been hanging in there for 3 years with grade group 2 and getting yearly, certainly getting PSA every 4 months or so, and getting an MRI yearly, and then assessing my risk, and also planning for treatment too, in case things go south. I've been looking at, I've been talking to radiation oncologists about treatment too. So, I don't know what else to say about it, but in Canada, I do agree with Stephen. There's a lot less resources. There's no payment for any of the genomic testing, and you'd have to do that privately, and even getting yearly MRIs has been a bit of a struggle for me too. Just like Stephen, said, one of my doctor refused to give me one. Said, "Well, you're stable enough," and so I got one, and I went to Washington and got Washington State in Seattle. I had to get a MRI there. So, but I'm fairly satisfied that I'm, and I also read that article about the cribiform too, and I was quite interested in it. And they were talking about a certain diameter being dangerous, though not all of it, like a quarter millimeter or larger or something. That was sort of the cutoff that they were using.
Yes, yeah, that's correct. And
so I don't know what the size is of
Stephen's
cribiform, but maybe I agree. I thought that that finding, they were basically saying Gleason grade is not as relevant as for metastasis as cribriform, or not even
Yeah.
that relevant.
And let's just hold on a second, because I just sent a note to the organizers. Lewis asked about what is cribriform and what is introductal. Guys, would you like to address that for people who don't know in the group what cribriform introductal is?
I'm writing to Lewis now, Rick.
I sort of looked it up while we were
okay.
chatting and saw that it's a rather aggressive.
Yeah, but for the sake of the recording, I think it's important. Would Mark or Dr. Mark or Dr. John or somebody else like to just talk about cribriform introductal for a second?
Cribriform introductal refers to the appearance of the prostate cancer cells on a biopsy or pathology sample of the cancer. And the particular appearance and location of the abnormal cells has prognostic significance for the behavior of the cancer in the future, in the same way that a Gleason score has prognostic significance. And therefore, it's something that gets reported on pathology reports, and something that has to be taken into account when you decide whether your treatment should be aggressive or conservative.
Lewis, remind me, did you have introductal or cribriform on your biopsies?
No.
Okay. The PROTECT study is a prominent study that was done in England, and they looked at IMRT, prostatectomy, and active surveillance. And it turns out the recurrence rate after, or progression after each of those, was the same. So while we agree that at best we are looking at putting this thing to sleep and keeping it in remission, I prefer the term no evidence of disease as opposed to durable remission, but I guess it's the same thing. But this study showed that there was no advantage. So we enter this whole prostate cancer thing thinking that, what can I do? I mean, that was my first thought when I got my biopsy result was, what can I do to get this out of my body so I never have to deal with it again? I will say that prostate cancer and my prostate have been rather boring for 5 years now, and I hope it stays boring for the rest of my life. But I don't think that anything that we do is going to make it go away and assure us that it'll never rear its ugly head again. And the studies bear that out, that we're fooling ourselves if we think that going into surgery is going to cure this.
Yeah.
Because it comes back, and when it comes back, then we'll say, why did I do this? And now I have incontinence or erectile dysfunction, or I went through the recovery and surgery and I'm still dealing with this. So I think I'd be real careful about making a decision for active treatment if active surveillance seems reasonable. In fact, fewer people who choose active surveillance are going to ultimately need treatment than those who have complications from doing the surgery. So it just doesn't make sense unless you need to really do that and have a good reason.
No, surgery I'm not thinking of.
Okay, good. Anything else for Lewis? Okay, Bob, did you need any time this evening?
Yeah, real quick, and I don't want to open up a can of worms. I had a consultation appointment with the doctor at University of Chicago Medicine, and we were discussing Decipher. So I hope this doesn't open up a can of worms, but he doesn't hold a lot of credence with Decipher, and his rationale is that when you have Decipher done, not only do they get the tissue, but then they want all this other information as well. So it kind of clouds possibly or interferes, if you will, with the results. It's not truly independent. I was curious if you guys fall in line with that rationale or not.
I don't. Speaking for myself, if you want a predictive test for whether a medicine is going to work, or a prognostic test to determine the possible future of a disease, if you look at one element, you'll get a certain amount of accuracy. And if you look at, there are many different elements that predict what's going to happen to us. If you look at two elements or three and combine them all into a test, you find when you look at the results of that, the accuracy gets better and better and better. So in my opinion, it doesn't cloud the issue, but makes it more accurate.
Well, his rationale on it was that the Decipher was based off of my original reading of 4 + 3 = 7. And when I had my second opinion by Dr. Epstein, he downgraded me to a 3 + 4 = 7. And he said they didn't resubmit the Decipher. So he said it's probably not as aggressive as what was originally thought based off of the original biopsy.
Oh, definitely have them recalculate then.
So that leads me up to my next portion, because thanks to Mark, when I had found him on Facebook, and he pretty much persuaded me not to go with focal therapy, which was Tulsapro, because I was getting myself all aligned for it, and hence that's how I've landed into this group. Right now, I'm trying to stay the course on active surveillance. I have an MRI scheduled here on the 24th of January with a perineal biopsy scheduled for the end of February. My question is, this is already planned, but is there a way or a different methodology to avoid the perineal biopsy?
So my thoughts would be the Epi-Switch test.
Yeah.
I think in looking at all this, how many factors go into a particular reading on the Decipher. There are some people who suggest that the Decipher may overcall it. I definitely think I would get on the phone with the people at Decipher and see if they can just recalculate what they have by changing the score on the tissue biopsy. But these diagnoses or our treatment plan shouldn't be based on just one piece of information. There are many factors that ought to be taken into account before making that decision. So I don't think I would just sit and say, okay, the Decipher says do this, run ahead and get treatment. That's just one factor in your decision making. The Epi-Switch PSA right now seems to be the most accurate, predictive in terms of do you need to have that biopsy, or might you just sit back and wait and continue with active surveillance? The other thing, if you have the biopsy now, is the ArteraAI would be helpful in advising you as that's tissue based, and that's going to advise you on the potential for active surveillance as well.
So Mark, the ArteraAI, is that in place of the biopsy or supplemental to?
No, ArteraAI is using the biopsy tissue and letting the computer read it instead of a doctor. And it looks pixel by pixel. at the cells within the biopsy. So it's analyzing each cell in terms of how it shows up and coming up with, yeah, this is okay, or we have concerns about this. So that needs biopsy tissue. The Epi-Switch tells you whether, okay, we did the MRI and it looks pretty much the same as it did before. Do you really need a biopsy? Epi-Switch will say, no, you don't. In fact, there's some discussion about whether the Epi-Switch says you wouldn't need the MRI. I think at this point, probably the best approach is imaging as well as a biomarker. And soon, hopefully, we'll know which biomarker is absolutely the best one, because there are a lot of them out there, and they don't always say the same thing.
So then, Mark,
Mark, what do you think of the 4K test? Are you familiar with that? The 4K score? Yeah. Do you think it has much ability to tell whether a biopsy is necessary or whether there's a chance of aggressive cancer? This is for everybody's information, as a blood test that measures different types of PSA and all that.
Yeah, I mean,
and the Epi-Switch is similar in that it works off a blood test as well. The exosome DX is a urine test, but I think that at least from the early data, because Epi-Switch hasn't been around as long, it appears that the 4K is one of the more accurate tests, but it doesn't approach the Epi-Switch.
Yeah. The other thing about the 4K is I think it's a more appropriate test for people who are trying to determine if in fact they have prostate cancer. It's really pitched at an earlier stage than Bob's.
Yes. Okay. Thanks.
I think that's one of the things that's really important. We have all these tests, and when we sit here, we're thinking, I'm going to do this test, and it will tell me good, bad, or where things are going to go. And it's very important that we understand how the test is validated and what questions they were asking when they said, okay, we have a test to look at this. It doesn't mean that that same test will help you. The perfect example is if you have a test that says, should you do AI or not? I'm sorry, should you do ADT or not? You get treated, and then you want to say, well, I'm going to monitor after I do the treatment. That isn't how the test was designed or tested. So we don't know if it's as accurate in the situation of follow-up after treatment as it was to tell us whether to do treatment or not.
Okay.
Okay.
So I'm hearing to get the MRI done, but then also after the MRI, get the Epi-Switch.
I probably would, if you're concerned. You said you want to try to avoid a biopsy.
Correct.
That would be one test that I would look at, because that's what it was designed to look at.
All right. Thank you, Mark.
Okay. John.
Yeah, I just want to add, after my Pi-RADS 4 MRI, I didn't want to go right to a biopsy, so I had the ExoDX, and that was over the threshold, and a 4K. So both said go to biopsy. So that was my determination, and they found the 4+3 or 3+4. So and the Decipher, it says on my Decipher, it's not based on my Gleason score. It's just based on looking at the samples. So I don't know, was that just brought up? So that's all I'm going to add to that. So I guess it's just based on the samples, not on the Gleason score, the Decipher.
Yeah, it's interesting you say that, John, because I was going to make that comment. I mean, I'm not sure how influential the Gleason score is on the Decipher, because what they're doing is they're looking at mutations and genomic information that they find in the tissue. They're they're not really looking at that Gleason score.
Yeah,
So
it's
sort of backs up what I was saying. Who's the doc? Who's the doc you're seeing at UFC, Bob?
Dr. Jagaya. I couldn't get in to see Dr. Eggener until March.
Yeah, so I really don't know him, but I think he's off base a little bit. I mean, if it was Egner that was saying that, I would say, oh my gosh, or one of the other guys that I know. But if it's one of the younger docs that hasn't been around, I wouldn't put a whole heck of a lot of weight on what he's telling you about Decipher. That'd be my view. Sorry, John, I kind of interrupted you. Go ahead.
No. I just wanted to add. I specifically saw that on my report, not based on Gleason score. So
yeah,
just wanted to add that.
You know, it makes good sense, because when they're doing this, they're looking to validate their test, and they want to know who it works best on. So it may well be that they're collecting this data to be able to say, you know, we're this accurate if your Gleason score is this, picking up a different Gleason score where we have another finding. So the more information they get, the better they will understand what their test means. Stuart.
Yeah, I just pulled up my Decipher report, and the use of the Gleason score is after they've done their analysis, when they do to assign the score and the risk. That's because they compare you to similar clinical groups. So I think if you called them, there's no question that they could adjust and report any change, because it's an after the fact calculation.
Then the Gleason score does influence the results of the Decipher, is what you're saying, Stuart.
It influences the report. It doesn't influence the analysis of the sample. Right. It's when they take their observation of and they want to apply it to a common group to say what your risk is. So I think if you call them and say, hey, I'm 3 + 4 instead of 4 + 3, they're going to reproduce the risk curve. And if anything, that may push it higher.
I think Decipher also asks about PSA.
Yeah. Yep.
Yes.
So that's something I found to be interesting as a result of my consultation. My PSA has digressed from 5.27, and now I'm down to 4.5. I know that if it was going from 4.5 to 5.27, there would be concern. But now, with it going down, he's almost saying, well, that doesn't really matter that much. Well, I don't understand how you can have it both ways. There seems to be some sort of inconsistency there.
Decipher test is particularly interested in people who have a rising PSA, isn't it? And then it predicts the chances of mutation in the future. Isn't that when you do a Decipher test, when your PSA is going up and you're wondering what to do next and what to expect?
I think it's the most common I see it is for active surveillance or not, and how aggressive one might be in wanting to treat or not. You know, I'm not sure about following in active surveillance. I haven't seen good evidence about repeated use of Decipher, you know, with subsequent biopsies. I don't know that that's been well characterized. I wanted to ask Joe, I didn't have a chance to ask you in the beginning whether you had any requests for comment.
Okay. Oh, we're running quite late. I do have an appointment with a radiological oncologist and on Friday. And I was wondering, just maybe a short answer. this is for Dr. Mark, about equipment. Should I be asking him what kind of they've ruled me out for SBRT because of my urinary size, and I mean my urinary issues and all that. So it would be like 20 or 25 treatments. How important are machines in this equation, and should I be asking them?
Well, ideally, the way to ask that would be things like, does the machine offer gating? And what size margins does the machine offer reduced margins? And I think you're going to find the only other, the CyberKnife S7 and Varian Edge might be helpful. I don't know that you'll have access to any of the MRI guided machines that have the gating and the like. So names that you'll hear will be TrueBeam and Varian Edge and CyberKnife S7. Those are the kinds of things that might be available.
Yeah, because I think even and I also talked to a doctor at the University of Washington, Fred Hutch, a radiologist there, and they don't have the MRI they don't have the MRI guided either. I think it's kind of and they're considered like a center of excellence. So I think that must be hard to get to. You'd have to go to maybe UCLA or UCSF or something,
UCSF doesn't have it either.
Oh, they don't have it either, huh?
No, it's somewhat limited. Again, the Varian Edge machines, which also are limited, have reduced the margins by about 60%. So I'm sorry, to 60% of what you might find in some of the other machines. So you're radiating less normal tissue. It also depends where your lesions are. If your lesions are close to the urethra or the bladder neck,
yes,
or posterior part of it, you're going to want a machine that's more precise and is going to try to address the movement. How do you quantify that? And is it worth spending $160,000 from Canada to UCLA? Probably not. But you do want to make sure that you're seeing someone, if possible. I mean, more important is someone that's not doing breast in the morning, then brain, and then rectal cancer, and then bladder cancer. You want someone who really focuses and understands.
Well, how do you tactfully ask if, do you just say, how many prostates have you done? Or
I think I'd ask whether, they're a generalist or whether they focus specifically on GU cancers.
Yeah, I think here they're all generalists. I don't think there's any.
Yeah.
In maybe not maybe in Washington they're a little more focused, but I don't know. But I have Medicare because I'm a U.S. citizen also, and Medicare Part A and B, so you have some access.
Come to UCLA.
Yeah, the only problem is if they do 22 treatments, I have to rent an apartment for a month.
I think you'd want to do the Prostate test and talk to them about SBRT.
Okay.
So I'm not sure I buy. I think the reason they might be concerned more about the urethra and the location is because they don't have technology that will compensate for movement or protect against that. So it may very well be that you are a candidate for SBRT if it's on a more exacting
machine. They had
machine.
a better machine or a more experienced crew or whatever. So.
Yep, exactly.
Does the radiological oncologist actually do the aiming thing, or is that just a technician that comes in?
Well, no, the machine does the aiming. What'll happen is the more and more artificial intelligence is involved and may do the first pass on the CT and the MRI and potentially on the PET scan if that information is available. It's fed into the computer, a combination of the radiation oncologist and the physicist. The physicists are very important, and we never hear about them. They all look over this plan it gets loaded into the machine. The new AI on Electa and on the more advanced Meridian machines are going to say, okay, today we're looking at all these spots, we're looking at the lesion. We can boost this one spot where we see the Pi-RADS 4 lesion, boost that up maybe 2 gray. And we'll go in from day to day and compare, and it'll say, I don't like this today. The machine will say that, I don't like this today. I would suggest you do this. And then it sends a text message and it pops up on everybody's phone, and all the people have to agree and accept this new or change in plan. That's called adaptive radiotherapy, where on a daily basis, the whole thing can be reconfigured if need be. So everybody is involved, but while you're actually going through the treatment, you're probably not going to see your radiation oncologist. They do the work between your planning visit and the actual first treatment. And there's a daily on-call radiation oncologist who's there that says, yep, I'm okay with what the machine says to do for this particular day.
Wow, I didn't have any realization of that process. All I knew is that they expect me to carry a lot of water in my bladder which is going to be an issue if with
I'm sorry about that.
One other thing I just want to say about what Mark was saying is, if you see your radiation oncologist has a PhD, which a lot of them do, there's a good chance that they're the physicist doing the planning as well.
Oh, interesting.
It can happen. I know that for my seeds, it was the radiation oncologist who also had a PhD from UCLA that did the planning. So sometimes they'll do the planning. Other times they'll use a what are they called, Mark?
Calypso.
Sorry?
Calypso?
No. What's the name of the guys that do the planning? The physicians, the physicists.
Radiation physicists.
There's another name for them as well, I think. I can't remember. Anyway, it doesn't matter.
So the one thing that's nice about the machines with the adaptive technology is they're less concerned with the bladder and the rectum, because they can say, oh, we can just adjust for it. I think it's easier on the team if it's close to the same thing every day, but they have the capability to adjust. So it becomes less, they don't have to be as crazy about, we want a full bladder and an empty rectum.
Okay, thanks so much. Yeah, I'll feed back what I hear from the doc and see what they.
Okay, Paul is other Paul is left. So I think we've covered anybody. Does anybody have any last thoughts?
No, but I want to give kudos to Norman, who stayed through the whole on his first visit. He's been here from beginning to end. Oh my gosh! God bless.
I thought you had to. I thought that was required.
Only the first time. Only the first time.
I'm trying to be a good guy. No, I mean everything you guys said. I'm a retired primary care doc, and so I thought I had a little bit more orientation to stuff. But I'm extremely impressed by all of you, docs and non-docs, in terms of the types of questions. So I'm learning stuff that I didn't know as a primary care doc, and I'm not even getting from my urologist and radiation oncologist now. So it was all helpful to me.
No, I'm glad you only fessed up at the end. Otherwise, we would have had to be a little more careful having another dog in the room. But I tell you what, you're probably Mark's a former GYN fertility surgeon, and Dr. John is a retired pain and addiction psychiatrist. So you're very welcome to join here, and we'll give you the same salutation we give Dr. Mark and Dr. John, and we hope you come back.
No, I don't have to be called doctor. Norm is just fine with me. I got to report to 2 sons who are ER docs. 2 out of my 3 sons are emergency medicine docs.
All right. Okay. Well, and Dr. Mark has a daughter who is also a naturopathic doc, an acupuncture. What is she?
Acupuncturist, Chinese medicine doc.
Oh, I've been through that.
And all that. I'm sorry, you're into that too, did you say?
Well, I have a weird CIDP, chronic inflammatory demyelinating polyneuropathy, which took 15 years to diagnose, even though I had access to Hopkins and all these good places. So at a certain point, I got some relief from going to an acupuncturist for 2 years.
And John has worked with that as well and has experience in at providing acupuncture services.
Yes, Dr. John has his own set of needles.
It's not a set. Come on, we don't. Yeah, my daughter asked, "Do you want to go back in the back room and wash off the needles so we can use them again?" It doesn't work like that, Rick.
Well, my acupuncturist was the only one that was listening to me. Everybody else was not really listening to me. So.
That's great. Well, thank you all. Have a good night. Keep your fingers crossed that we just get a lot of hot air tomorrow and not hot air because of the flames. We're ready for all that to be over in LA.
Yeah.
All right. Yeah.
Take care and thank you for coming. See you in 2
weeks.
weeks.
Everybody.
Thank you all.
Good night, everybody.
Bye.